Okay, welcome everyone to our webinar, which is today hosted by the Scientific Committee together with the Histiocytosis Association. Next slide, please. Just quickly about the Histiocyte Society. It's a nonprofit group with over 200 physicians and scientists from really around the globe. And we are committed to advancing knowledge and improving outcomes for patients with all histiocytic disorders. And we focus on clinical and basic research and on education. And the session today is hosted by the Scientific Committee and the Histiocytosis Association. So just a few housekeeping rules. All the participants are muted. If you have any comments, please submit them via the chat feature in the webinar panel. And we will see this, so the staff and the panelists, and the chat is in the controls at the bottom of your screen, which you probably know by now. And after clicking, then the chat window appears and you can type your message and just press enter. And if you have any questions for the speakers, which we hope, then please put them in the Q&A box on the left. So the questions will be addressed at the end. So please indicate who the question is for. Also, please put the question for staff in the chat box and like a question if someone else has posted a similar question before that. And due to time constraints, we may not be able to answer all the questions. Maybe, sorry, I just thought that for the questions, I think since both topics today are quite different, we should have the questions immediately after the specific talk. So if Melissa goes first, we will post the questions to Melissa after her talk. So yeah, finally, I'm thanking our sponsors, the Histiocytosis Association and the Artemis Association and Histio UK, who all support us. So I think we are good to go.
Am I going first?
Yes.
Okay.
No, sorry, Deanne is going first. She will just yeah, brilliant.
Thank you. Hopefully everyone's able to see the slides. I'm going to briefly introduce you to the Histiocytosis Association so that we can talk a little bit about the work that we do, as well as our annual research program and how that tailors into our partnership with the Histiocyte Society. So for those of you who are not familiar, we're a nonprofit based in New Jersey. We were founded in 1986 by Jeff and Sally Tohill. Their daughter was diagnosed with LCH, and we have a dedicated team and a volunteer board of trustees. This is just a quick little visual of how our team and board are made up, and we have various committees that support all the areas of our mission. Our mission is to raise awareness about histiocytic disorders, providing educational and emotional support and funding research leading to better treatments and a cure. We support research as well. So we have an annual research program that I'll talk about at length, but we also sometimes will partner with various projects in order to help disseminate information or to provide the patient voice, patient experience. We share what we learn with the patients in the community to help expand knowledge and awareness. And we provide educational resources, including a physician directory. So if you're not currently signed up for our physician directory, I encourage you to reach out to us, info@histio.org, or to visit our website and sign up. So that way we can connect you with patients. And we have a variety of other programs focused on education. And then a huge aspect of what we do is to provide emotional support through outreach events and virtual opportunities. A little bit of our impact: we've helped over 19,000 patients and families across 119 countries. We've funded over $7 million in research, totaling over 190 research grants since 1990. We have several meetings and webinars throughout the year. I mentioned our physicians directory and then our ongoing support. And this is just a list of some of our resources and educational programs. I encourage all of you to connect your patients and families with the association if they're looking for connection with other histiocytosis patients or caregivers. We have a variety of different resources available for them. And then our team is committed to being there to help answer questions, to walk them through their histio journey as best as we can. So we're here as a resource, and we just encourage you to share our information with them so that we can help and be there with you to partner with the patients through this experience. And we know it can be very isolating and devastating. And so everything that we do is to be there for them. And we have been partnered with the Histiocyte Society for 35 years. We have a unique partnership where the association serves as the secretariat for the Histiocyte Society to provide administrative support to ensure that the society can remain focused on research. And there's just a list of the ways that we work together. And then our partnership is also further demonstrated through our annual research program, which I'll dive into briefly. So each year through the research funding cycle of the association, the applications that are received are reviewed comprehensively by the Histiocyte Society Scientific Committee, and then that information is provided to the association's board of trustees, and that's how we select the best applications for funding. And our cycle opens each year in the spring, and that review takes place once the application window closes in the summer, and then we announce the awardees at the end of each year. Our annual grant process supports scientific research investigating causes and mechanisms and improved means of treatment for histiocytic disorders, and we do support all histiocytic disorders. And the evaluations are based on science, feasibility, and relevance. All proposals are expected to address one or more, so it can be a combination of histiocytic disorders that you are investigating. And then the evaluation process that we have is modeled after the National Institutes of Health process to ensure an impartial and transparent approach to funding. Our application window this year is available between April and June, and I will mention that we extended our application deadline. It previously was set to close on June 1st. Now we are extending that through June 10th at 11:59 p.m. So you'll have the full day through June 10th to submit applications. That review will take place between July and September of this year, and then the evaluated applications will be shared with the association's board of trustees to make funding decisions by November. And then announcements and disbursements are made by the end of the year. And I will pass over to Caroline to talk a little bit more about the scientific committee. And again, thank you so much for all that you do, and we really appreciate the opportunity to partner with you.
Hi, thanks. So yeah, I just have 3 slides. I quickly want to introduce you to the scientific committee. Here on that slide, you can see all the current members, and so we are from all around the world. We have members from Asia, Europe, and North America, and also have very different backgrounds. So we have basic scientists, pediatric oncologists, adult oncologists, pathologists, and hopefully we are therefore able to cover all different questions and also grants in their complexities. Next slide. So here you can just see how it works, how we review the grants. So you submit the grants electronically, and then they are remotely evaluated in the first round by all the members of the scientific committee. And we have decided this year that we will have 3 main reviewers per grant, and the allocation to the grants will be by self-assignment. So if there is no conflict of interest and you have the feeling that you have something to say or are able to properly review this grant, you can say, I would like to review this. And however, all members of the scientific committee read and score all the grants, and the main reviewers write a report on each of the submitted grants. Then they are submitted, and we can have a look at this. And then there's an in-person meeting of all the members of the scientific committee, which takes place during the annual meeting. And then we discuss each grant and score it and rescore. So you can also change your scoring if you have second thoughts and think you should evaluate this differently, and rank together all the proposals. And this ranking is then submitted to the Histiocytosis Association And they finally decide which grants they fund or they don't fund. So we just give a recommendation. And last slide, how do we score? So we are utilizing the NIH scoring system, which has a 9-point rating scale from exceptional to poor. And then there are 4 main areas. The one is the scientific impact, where we score for novelty, scientific excellence, and how it generally advances the field. And it's also an asset if you have some preliminary data to show. The relevance, especially for this grant, is really, does the project aim to lead to better treatments and a cure? So it has to be histiocytosis specific. And we are also asking, to what extent does the proposed research address important challenges in the field? Regarding feasibility, as always, no risk, no gain. You can submit a high-risk project, but there should be enough feasibility, and especially numbers of samples, patient samples. Do you already have access to them? Can you really address the questions you are asking? Do you have the required scientific expertise, collaborators, and are the other resources realistic? And overall impact is just a question: will this project move the field forward and make an impact in the setting in which it will be formed? So I don't know, does anyone have some questions regarding the scoring? Or can we go to the first talk? No, I think then we can start with the first talk.
And that's me, right?
Yeah, that's Melissa. So just to quickly introduce Melissa, she's an assistant faculty member of the Critical Care Medicine Division at St. Jude's. And her research interests are HLH and abnormal inflammation in different settings. And today she will talk about ruxolitinib in HLH. And we are very much looking forward to your talk. Thanks, Melissa.
Sorry, just sharing my slides. It takes a minute. All right, so let's get this. Oop, start from the beginning. All right, I think I'm finally there. Okay, so thank you for that introduction. And so what I'll mainly be talking about is the HLH Ruxo trial that I am the PI for. And then my lovely co-I is Kim Nichols, also here at St. Jude. She's an oncologist and does a lot of basic research in the setting of HLH as well. And the long name of the HLH Ruxo trial is the use of the response-adapted ruxolitinib containing regimen for the treatment of HLH. And this particular trial is run through NACHO, or the North American Consortium for Histiocytosis. We do receive funding and drug from Insight for this particular trial, so just keep that in mind. So going all the way back, HLH really is a story of cytokines and hypercytokinemia. Whether you're looking at primary HLH or secondary HLH, there are numerous cytokines that are elevated with very specific key players like IL-10, interferon gamma, IL-6, for example. And these cytokines really are important because they are responsible for in part for the phenotype that we see in HLH, and they are important as they mediate the morbidity and mortality that we see in HLH. And so as far as a therapeutic approach, inhibiting cytokines themselves rather than just targeting the immune cells that are responsible for what we see in HLH has become an attractive approach for treatment of HLH. And here I'm showing an example of one way that we could go about this, which is neutralizing different types of cytokines. And in here, we're neutralizing interferon gamma, where you're binding up all this cytokine, or you're binding the receptor in the example of tocilizumab, and thereby preventing the cytokines from being able to signal. But another potential approach that you could take is actually targeting the intracellular signaling of cytokines. And so a lot of the cytokines that we see that are really important in the pathophysiology of HLH actually signal through the JAK1, JAK2 pathways, as you can see here. And so we could potentially look at inhibiting this pathway, this JAK kinase, and thereby inhibiting cytokine signaling as a potential therapeutic option for HLH. And so we started looking at the use of a Janus kinase inhibitor, ruxolitinib. So ruxolitinib is a JAK1/2 inhibitor, and it is oral, easily and excellently bioavailable. So whatever patients take, you get good blood levels. It has a short half-life, so it has the potential to allow for dose titration, whether you need to increase the dose to effect or reduce the dose for toxicities. And it targets HLH via another mechanism other than what we typically use with etoposide and dexamethasone. And it has the potential to be synergistic with those agents, allowing for dose reductions in things that we don't necessarily always want to give, such as etoposide. And it is FDA approved within the United States and is used in a lot of other indications. And so we have a really good idea of what type of toxicity profile and what we need to be monitoring within our patients. Of course, before we tested this, we started looking at opening a trial and looking at this in humans. We, of course, looked in mouse models first. And so in Kim Nichols' lab, they looked at primary HLH and secondary HLH murine models, gave them ruxolitinib. And what they saw is significant improvement in hematologic dysfunction, the overall cytokine storm, so reduction of cytokines, an improvement in the organomegaly that we typically see within these two different models, as well as reduction in CD8 T cells and CD8 T cell activation and neutrophil activation. But there seems to be potentially another thing that would make ruxolitinib a really good option for therapy, which is it seems to be synergistic with other HLH-directed therapies, particularly dexamethasone. So Lauren Meyer in Michelle Hermison's lab in collaboration with Kim Nichols looked to see what is it about HLH that leads to dexamethasone resistance. And so what they found is that dexamethasone resistance really is driven by hypercytokinemia, mainly through IL-2 and IL-12. And this is specific to dexamethasone resistance. And it does so through increasing expression of anti-apoptotic proteins, BCL2, BCL-XL, and MCL1 in a PSTAT-dependent manner. And so what ruxolitinib did was resensitize these cells to dexamethasone-induced cell death, also in a dose-dependent manner, because it inhibited the signaling of IL-2 and IL-12 at the JAK1/2 level. So with all of this in mind, how we kind of built the HLH Ruxo trial is that, of course, when we're thinking about treating our patients, we want to treat the trigger and always look for an infectious trigger, for example. And then we wanted to use ruxolitinib because of its ability to inhibit multiple key cytokines that are known to contribute to the pathophysiology of HLH, but also take advantage of this synergistic effect with steroids and enhancing T cell apoptosis or immune cell death that is needed to treat this disease, as well as the general immunosuppression of steroids itself. And then in patients that need it, add etoposide for additional T cell ablation. The central trial objectives for the HLH Ruxo trial is we wanted to repurpose ruxolitinib for the treatment of HLH as a frontline and salvage therapy. And we wanted to look at potentially doing kind of protocolizing, for example, a response adapted therapy for HLH so that patients only get the amount of drug or what drug that they need, but in a more protocolized manner so that we could test that. And here are our other additional trial objectives or things that we're looking at, including long-term outcome. The patients will be followed up to a year after they're on trial. Ruxolitinib, PK, and of course, other things like time to response and transplant. We have two different arms to the trial. We have a frontline arm and a salvage arm. The frontline arm is actually split into two different phases with a safety phase and an expansion phase. And really in that safety phase, what we're doing is getting the maximum tolerated dose for this particular indication, as well as when we're using it with additional agents such as etoposide. And we're anticipating 6 to 12 patients in that group. And then the frontline expansion phase, we're recruiting up to 30 patients. For the salvage arm, we're recruiting up to 20 patients in that arm. Our inclusion criteria for the trial is we're looking at pediatric patients and young adults, obviously with evidence of active disease. And for the salvage arm, they have to have previously failed standard of care therapy, and that's etoposide and HEG-based therapy. If they have only failed anti-cytokine-based therapy, then they do not meet the inclusion criteria for salvage. We're looking at we are excluding isolated CNS disease, malignancy, and rheumatologic disorder. So all in all, what we're looking at is primary HLH patients and secondary HLH patients that have disease because of infection, for example, like EBV. For the treatment, the treatment for the frontline safety phase and the expansion phase and salvage arm are different. And so the main difference is that in the frontline safety phase, we're starting all 3 drugs up front: etoposide, ruxolitinib, and dexamethasone. Similar to HLH-94 in 2004, the patient's dexamethasone is weaned every 2 weeks as long as they're doing well. And then you can see we've reduced the amount of etoposide that's given even within the first 2 weeks. So going from biweekly to weekly compared to the HLH-94 and 2004 protocols, because we have this underlying backbone of ruxolitinib. And in addition to that, within this particular group, if they achieve a CR by week 4 or after that point, then they can actually have their etoposide held at the discretion of the PI, allowing for overall reduction in the amount of etoposide that a patient is seeing. The approach that we're taking with the frontline expansion phase and salvage arm is we're starting the patients only on 2 drugs and adding etoposide as needed. So if they have a favorable response to therapy, then etoposide wouldn't be needed, and they would continue on dexamethasone and ruxolitinib for the entirety of their therapy. And then if they have an unfavorable response, then etoposide is needed. And so we're really basing that on what the patient needs. So do they need etoposide? Here are all 10 sites that we have for the HLH-Ruxo trial. They're scattered throughout the United States. Currently, we have 3 frontline patients that enrolled, 1 salvage patient that has been enrolled so far. And we currently do not have any dose-limiting toxicities. And the AEs that have been reported so far are really what we expected with the drug, which is cytopenias, elevated cholesterol, and infection. And so far the regimen has been really well tolerated in these initial 3 patients, but of course that's limited, or excuse me, initial 4 patients. Of course that's limited because we only have 4 patients enrolled thus far. I wanted to spend just some extra time on the exploratory objectives, because this is where the Histiocytosis Association funding really helped us out. Which is we wanted to look at evaluating early markers of response or biomarkers of response within this group. We also wanted to have a little bit more in-depth exploration of the pathophysiology of HLH, and then look at how cytokines, the cellular repertoire, and gene expression changed over time with therapy. So getting a really good idea of what are we actually doing with our treatment. So to investigate this, we wanted to take a 3-pronged approach for the immunology studies. And we did this with the help of Tim Forloggi and his lab. which is pretty much an infectious disease immunology lab here at St. Jude. And he has particularly expertise with single cell RNA sequencing. And so that's one of the reasons that we approached him. So we're taking this three-pronged approach with cytokine panels, deep immunophenotyping with flow cytometry, and then of course the single cell RNA sequencing in some of the samples. And we have weekly research samples that we are obtaining in all the patients through weeks 1 through 8. And then we have some additional samples that we're obtaining kind of scattered throughout the follow-up period. But of course, these are the main samples that we're interested in. So our approach for these samples is, of course, we were wanting to do flow cytometry to immunophenotype, but in addition to that, we're using this flow cytometry to help separate out the different cell populations so that we can further use single cell RNA sequencing on them. And so we'll be looking more specifically at the myeloid cell population, T cells, and NK gamma delta T cells as well. And the reason that we became interested in single cell RNA sequencing is because transcriptomics is, while it's been done in HLH, it's mainly been bulk RNA sequencing. And so what single cell RNA sequencing can offer us is it allows us to do two things. It gives us the ability to determine gene expression in a different immune cell groups rather than just looking at the overall gene expression that in the blood and within all of the immune cells. And then it allows for us to evaluate low frequency cells that may be really important for the pathophysiology of HLH, but are going to be missed with bulk transcriptomic methods. So one of the things that we were worried about whenever we were thinking about this approach is what is the feasibility of this, particularly in a group of patients that we know are going to have relatively low white blood cell counts, either because of the HLH itself, because of bone marrow suppression, or because of the therapy that we're giving them, such as etoposide. And so what we did is we initially took St. Jude biorepository samples. So we had 3 St. Jude biorepository samples from oncology patients that were just available. And then we also had a healthy donor, obviously, as our control, and started out and did this analysis on those patients. And as you can see, the cell samples were not great. There was one sample that only had 600,000 cells. But what we were able to do is we were able to go ahead and sort the 2 different cell populations. We just sorted NK cells and T cells in this group. We didn't really sort out to the myeloid because we were just interested in those groups of cells. And we were able to perform single cell RNA-seq, and we're very successful in it. And so you can see how in these patient populations, based on the gene expression, they were clustered into the different types of immune cells. And then further subclustering was done for the NK cell subclusters, for example. And then this is more of an example of what kind of information we can get from single cell RNA-seq. And so this is the T cell group from that single cell RNA-seq. And you can see how the clusters of T cells have split apart between patient 1 and patient 2 based on their expression. And then based on and then we can get even more information from these BioLim plots, where particularly in patient 1, you can see that there's an increase. So there's, based on the expression here, there's this patient had increased cellular immunity, increased effector antigen specific CD4 T cells, genes related to migration of effector T cells, and also upregulation of genes that promotes increased survival of NK cells and CD8 T cells. And this all makes sense in the setting of an active CMV viremia infection that this particular patient had. So this is the type of information that we can get from single cell RNA-seq. So based on the good information that we got from that and the ability to do single cell RNA-seq just in those first 3 samples, we felt really comfortable moving forward with testing our first HLH Rexo samples, because those, as Kim says always, are very precious, and it's true. So our first 3 patients samples have been tested using this methodology. And we wanted to look at, get an idea of how are things changing over time and what are the important time points going to be. And so these are the time points that we chose. So these are the study days here. And in this initial look, we looked at 2 of our frontline safety arm patients that were on all 3 drugs, and then 1 salvage patient that was on Rux and Dex alone. And so I don't have any amazing information to give you, particularly on the single cell RNA-seq, because we're still working on the analysis, because this particular modality gives you insane amounts of information. But what we could take away from our initial testing is that really the largest changes in everything that we looked at, cytokines, the immunophenotyping, and single cell RNA-seq, all occurred really between study day 1 and study day 8. As you can see here, our IL-10 and CXCL9 dropped precipitously with continuous inhibition of those 2 cytokines in particular. And from that point, really what we saw over time is a very stable cellular repertoire and gene expression for the rest of their treatment while they're on through week 8 of their therapy. And so really, based on this information, we'll be focusing in on single cell RNA sequencing analysis on study day 1 and study day 8. I would like to thank my lovely co-I, Kim Nichols, Kristen Ryan, who's our wonderful HLH Ruxo coordinator, Tim Florlagi, who's been helping us with all of our basic science research and immunology research, the Nacho team that helps us run this study, and that consortium, and then of course the Histiocytosis Association for their support. And with that, I'll stop and answer any questions you may have. And if you do have any specific questions later on, this is the HLH Ruxo email, so feel free to use it. It goes to me, Kim, and Kristen.
Hi, so thanks for the interesting talk. The Young Ming just posted a question, and she asked whether all patients with HLH treated by the same regimen with all 3 drugs, including etoposide, dexamethasone, and ruxolitinib, regardless of the severity.
So yes, for the frontline salvage patients, they were treated with all 3 drugs. And you have to keep in mind, if they're meeting HLH 2004 criteria, they're usually fairly sick. So yes, but all of them did receive the all 3 drugs up front. For the front line, we did have that 1 salvage patient that only had the 2.
Randy Cron is asking, what are you hypothesizing to see with the cell sequencing?
Yes, so single cell RNA sequencing really is a exploratory modality. And so far, I think what we're gonna see is a shift in kind of the cells that are predominant. And so we're going to have a good idea of how are we affecting gene expression. And that gives us a lot more information about, rather than just looking at how are the cells changing as far as their immune phenotype. So I know that that's a very vague answer, but that's all I can give you.
I think it makes totally sense. That's one of the advantages of the 10x system, right? So to see what's there on the single cell level. So there's no other questions. No, Kim is asking. She's saying we're looking for biomarkers of responsiveness or not to therapy. Just a question which probably this is not possible, but I mean, a lot is happening in the first week, right, of treatment. It would be nice probably to have additional samples like day 1, day 2. This is probably not possible. Or can you do this, or can you incorporate this later?
You know, I think we could consider incorporating it later. It may be interesting to see what's happening at study day 1, study day 4, and study day 8. So you're getting at least one more picture of what's happening within the first 24 to 48 hours. And then again, as you're approaching that week, because you're right, there are a lot of things that are usually happening in that first week, with a huge, even clinical change happening within that first week period. And so that's one of the beauties of going ahead and at least doing this preliminary analysis, knowing that that is what we saw is just this massive, like the biggest switch really did happen within the first 7 days. I mean, based on the single cell RNA-seq data, really what we saw was a huge transition from effector cells to more of a memory cell population. So it really is changing how the immune system is transitioning the immune system to a completely different state.
Yeah. There's one question from Deepak, and he's asking, are you anticipating worsening liver function with Ruxo with previously irritated liver from HLH?
That is certainly something that we are following carefully. And so far, granted, we only have the initial patients, we're not really, if anything, the liver dysfunction improves as the HLH gets under control. But it certainly is a possibility with with the transaminitis that we can see with ruxolitinib, but we're watching it carefully.
Yeah. Kim answered a question from Yong Ming. She added something. She said you were forced to use all 3 drugs by the IRB for the initial 6 patients.
Yes, yes.
Then there's a question whether you include patients who receive alemtuzumab or abatacept in frontline and salvage arms.
Can you repeat the question? I'm sorry, Caroline.
The question is whether, sorry, I have to find it. Whether you, yes, whether you include patients who have, more or less, who have not had a standard frontline therapy. No, you don't, right? Yeah. Whether you include patients who have had alemtuzumab or abatacept in frontline and salvage.
Yeah.
Okay, Randy now says, without an arm of patients who are not receiving treatment, how do you know what is response to therapy versus natural disease cause?
Not arms of patients
who are not receiving treatment.
I mean, we don't. He's right. That's a limitation. Obviously, we always have a control that we're going to include, which is a normal apheresis sample, but we don't have other HLH that is not included on the protocol that we're looking at within our exploratory games. I mean, we're mainly more interested. I mean, I get your point, Randy.
Then there's a question from Gaurav. Exploratory question. Do you think Ruxo has a role in malignancy-related HLH, given the poor prognosis?
Yes, and yes. I think it could be helpful in the setting of malignancy-related HLH. I do think it could potentially be helpful in the setting of rheumatologic, so MAS, for example. But whenever you're coming up with a protocol, you can't include all of those patients in there because you end up with a heterogeneous mess that's really, really hard to make definitive conclusions on. But I do think it potentially could have a role in malignancy-related HLH as long as you're treating the underlying malignancy with whatever chemotherapeutic regimen you're going to use.
Okay, I think we have to stop here. There are still a couple of questions. Perhaps, Melissa, you can read them and then answer directly.
Sure. And Kim, if you want to answer some of these questions with me, feel free.
Yeah. Okay, and we go to the next talk, which is by Jasmine Francis. She's associate attending at the ophthalmic oncology service at MSK. And her research focuses on intraocular tumors. but she is now, luckily for us, also looking at patients with histiocytosis, and will tell us about ocular findings in this patient group.
Hi everyone, thank you very much, Caroline. We have about 15 minutes left, so I'm going to give you a brief overview of ocular findings in histiocytosis. I do want to give a big shout out to my colleague Eli Diamond, who I work with at Memorial Sloan Kettering. Without his partnership and sharing of his patients, I would not have had the opportunity to see into the eyes of so many histiocytosis patients and to tell you about this today. Let me see, I have no financial interests or commercial relationships. And I'm going to divide my talk into how histiocytosis, the disease itself, affects the eyes and vision. And then I will also touch on how treatment of histiocytosis can also affect the eyes and vision. So starting with how disease affects the eyes, we looked at our cohort of approximately 130 histiocytosis patients, and we determined that 40% of histiocytosis patients have the eyes as a site of their histiocytic disease. So it's actually a pretty profound site of disease, and there are various layers of the eye that can be involved. And for those of you who are not ophthalmologists or are a little rusty on your eye anatomy, I'm going to go through some of the anatomy as I talk about the sites of disease. So I'm starting here with the eyelids, and we'll demonstrate here a xanthelasma, which is a raised yellow lesion, typically in the medial canthus in the upper or lower eyelid. These are painless. They sometimes correlate with cholesterol levels in the patient, although very often they do not, and they can in fact be a site of histiocytic infiltrate. If they do not bother the patient, they can be observed, although they are a very good biopsy site. These are biopsies that I will just do in the office, and they offer a rich supply of material for genetic profiling. Here's a patient of mine 7 days after a biopsy. And then here again, approximately a month later, and you can see that the biopsy site heals very nicely with just a very faint scar. Now moving on to the orbit. So this is basically all the soft tissue which is around the eye. I think of it as everything but the eyeball. The orbit is composed of this bony orbit, bony cave, and the eye sits within this cave. And histiocytosis can accumulate within the orbit, as I'm showing here, and the symptoms that patients will get can be blurry vision, diplopia, or double vision. They can have proptosis with the eye sticking out. The eyelid can become puffy, and they can develop ptosis. And what's important is that there's a very small fissure where the optic nerve enters the bone to communicate with the brain. And if there is disease in the orbit, then this can compress the nerve and result in an optic neuropathy. An optic neuropathy is damage to the optic nerve. Patients can have a variety of different symptoms, but typically they will report blurriness of their vision. They can have a change in their color vision, and they can have visual field defects. In fact, a visual field test, which is something that we do in the office, it takes about 7 minutes per eye, is a very good partially subjective evaluation of vision. Here I'm showing you a visual field that is abnormal, and an appearance of an optic nerve, which you can appreciate here looks less pink and more pale than a normal nerve. Just wanted to add this slide here. This is a patient of Eli and I. You can see that there is histiocytic infiltrate within the orbit, as shown here on the MRI. And after treatment, which we gave using an intra-arterial technique, so intra-arterial delivery of melphalan to various vascular distributions to this multi-compartmental tumor, we were able to result in an impressive reduction and regression of the disease, which has now had a sustained response over a couple of years. And this patient's vision went from about light perception, which we would certainly agree is a legally blind vision, to now being 20/20 in that eye. And you can read more about that work here. Moving on to the anterior segment of the eye, or the ocular surface of the eye. Here I'm showing you different examples of histiocytic disease on the surface of the eye, including the cornea here and the sclera there. Patients do have symptoms from this. It can include redness, an uncomfortable eye. They often describe the eye as being hot, having a pricking sensation, discomfort. Sometimes the pain can radiate behind the eye as well. And the key to this is to recognize that this is histiocytosis and not just general inflammation, and to treat the underlying cause. Topical NSAIDs such as ketorolac eye drops can be helpful, as can topical steroid drops. I'm showing you here an example, bottom right, of an eye that has histiocytic infiltrate of the episclera, and after being on a MEK inhibitor, cobimetinib, there is an impressive response to treatment. And then here on the lower left is a patient who had refractory scleral disease, refractory to cobimetinib, and following IA intraarterial melphalan had a very nice response. Just checking the time here. Now talking about the anterior chamber. So this is a part of the eye that is bordered from the cornea, which I'm highlighting here, and the iris. This is called the anterior segment, and behind the anterior segment is the lens of the eye, very much like a camera lens. And it is possible to develop inflammation within this chamber. I'm showing it here as this yellow lump within the anterior chamber of this plastic eye to demonstrate where this inflammation is, but it's not quite as obvious when we examine patients in the office and we have to use our slit lamp and our other instruments to be able to appreciate tiny little specks of white cells in this chamber. Patients typically will report pain. Probably the most important symptom that patients will have is photophobia, so sensitivity to light, and very often they will come in wearing sunglasses and are not very happy when they have to take their sunglasses off for flash photography. The important thing in terms of treatment is, again, to recognize that this could be histiocytosis and to treat the underlying disease, but also symptomatic relief can be achieved with using steroids, which are either topical or systemic, using a topical cycloplegia, which is a drop which dilates the pupil and relaxes the ciliary body muscle in the eye and relieves the sensation of pain. Here is an example of an eye that has uveitis. You can see that the iris is not a circular shape because of scar tissue that has formed from the inflammation, but following treatment, this lady had very nice resolution, and she was able to have a circular pupil back. Now moving on to the posterior chamber of the eye, and what I'd like to highlight here is the retina, and particularly the choroid. Just to give a demonstration of what the retina is, it's basically a wallpaper layer in the back of the eye, and we use our instruments and dilate the pupil, and that allows us to have a view of the back of the eye. And to orient you here is the optic nerve, here are the blood vessels of the eye, and this sort of dark area in the center is the center of the vision, and therefore the most important part of the eye in terms of vision. If you have a problem in this central location, you will have a problem with central vision. We use what's called an optical coherence tomography. This uses light to generate a cross-sectional image of the retina. This is considered normal. You can see here there's dipping down, and that dip corresponds with the fovea. So these linear layers that I'm showing is the retina. And then beyond that, where there is sort of a circular pattern, is the choroidal layer, which is a collection of blood vessels. we use something called an Amsler grid, which allows us to determine if patients are having symptoms from the retina on their vision. And so I'm demonstrating here metamorphopsia. So this is the notion that patients, instead of seeing a straight line, they see a curved line. And then on the bottom, at the bottom here, I'm showing a defect in vision, which could be called a visual defect or even a scotoma. So histiocytosis patients can have disease in their choroid. So again, demonstrating that the yellow here is the histiocytosis. It can accumulate in this orange layer, and then the retina sits over the top. And so because the retina is being disturbed by the underlying choroidal layer, patients can have secondary problems with their retina and therefore can have visual symptoms. Here is an example of what histiocytosis in the choroid looks like. So this is pretty classic. There is an amelanotic yellow feathery infiltrate in the retina. This is what it looks like on OCT. So you can see the retinal layers here actually look pretty good, but there is an elevation within the choroidal layer. And patients can have blurry vision or the metamorphopsia, which I showed. And this is what the choroid can look like after treatment. So you can see that the choroid has now flattened out and it has resumed the normal vascular pattern of the 3 vessel layers that typically reside in the choroid. I'm giving you some other examples of 13, well, here I'm showing you 12 eyes with histiocytosis in the choroid, and you can begin to see that they have a pretty characteristic appearance in the eye, but also wanted to demonstrate that in fact some patients can have problems with their retina, with their choroid, without it being obvious when we examine the eye. And so we have looked at histiocytosis patients, compared them to normal controls, and we have demonstrated that patients with histiocytosis will have on average, will have a thicker choroidal layer. So let me just show you this slide. On the left here, I'm showing you a normal retina and choroid, and the choroid here, you can see the measurement is approximately 250 microns in thickness. And then here on the right panel is an example of a patient with histiocytosis, and you can see the choroidal layer here is almost double what is normal. And of all the patients that we looked at, about 80% of eyes had a subfoveal choroidal thickness greater than the mean normal, which is 250 microns. I wanted to thank the Histiocytosis Association for a grant allowing us to delve further into this, and I look forward to sharing more of this information later. I'm now moving on to how treatments can affect the eye, and I have 5 minutes, so I'm going to be efficient here. So a cataract is a clouding of the lens. You can see an example here. This is painless. It can result in blurry vision, and patients will normally describe that they have difficulty driving at night and difficulty with glare from the oncoming traffic. Steroids can escalate the onset of a cataract, as can radiation, and this can either be observed or it can be surgically extracted with a 20-minute surgery. Showing you again here an example of edema or swelling within the retina. This is painless but can result in blurriness of vision, and 5% of patients on a BRAF inhibitor can develop this, and that steroids and other anti-inflammatories can be helpful at addressing it. Moving on now to talk about accumulations of fluid that can occur under the retina. If you look down at this bottom panel, here's a nice example of fluid under the retina pushing up the retina, and you can understand why patients then have metamorphopsia from this disturbed architecture of their retina. Approximately 15% of patients on a MEK inhibitor will develop this, about 20% of patients on an ERK inhibitor. And the key thing that I tell patients is that if they remain on drug or if they come off drug, the bubbles of fluid that they develop will go away on their own, so they are reversible. Now, MEK inhibitors or any other inhibitor of the MAP kinase pathway can also result in a blockage of the blood vessel or a vein occlusion, and this occurs in approximately 0.5% of patients. I have just over a handful of patients that have developed this, and in all of those patients we were able to get their vision back to normal with a combination of observation and anti-VEGF, so bevacizumab injections in the eye. So it is possible to recover vision afterwards, even though vision loss can be pretty profound when it occurs. And then lastly, last slide here, just to show that some MEK inhibitors can result in an elevated pressure inside the eye, and elevated pressure inside the eye can put pressure on the nerve and result in damage of the optic nerve. This is something that is avoidable if we know that the patient has high pressure, because simple glaucoma drops can be used to lower the pressure in the eye. Although I should also add that steroids can result in an increase in pressure, as can on occasion radiation. And so in conclusion, there's a wide variety of ocular manifestations of histiocytosis, both from treatment but also from the treatment effects. That there are some exciting targeted ophthalmic treatments, which are a new area of exploration, and new treatments within histiocytosis are very promising, but it's advisable to have careful monitoring of the eyes because of the potential side effects. And just to mention our histiocytosis service at Memorial Sloan Kettering. And here is my email address, should there be any questions. And again, thank you very much to the Histiocytosis Society and Association for having me speak today.
Thanks a lot, Jasmine. Randy Cron asked a question. He writes, how frequent is eye disease at presentation for histiocytosis? Do you recommend inpatient ophthalmologic exam when histiocytosis is on the differential diagnosis?
Would you mind repeating the very beginning? It's I got everything else, but the beginning.
How frequent is eye disease at presentation for histiocytosis? Any eye disease?
Yeah, so we believe it's about 40%. So 40% of patients will have some form of histiocytosis somewhere in their eye, whether it's the eyelids, the choroid, the optic nerves, etc. In terms of whether patients need to be examined inpatient, I don't think it's such an urgency, but I do think that it's advisable for patients with histiocytosis to be seen by an ophthalmologist relatively early on in their disease.
Thanks. I mean, this is something, so if it's, let's say, what would you suggest doing? Or what's the minimum? If a patient says, okay, I don't have any problems with vision, would you still recommend this?
Yes. So our typical protocol at MSK at Sloan Kettering is for any new patient to be seen by me for two reasons. One is to determine if there is in fact histiocytosis in their eyes, and we think it's actually more common in non-LCD patients. And secondly, it gives me an opportunity to explain the potential side effects of targeted agents for their disease. So when I see them for the first time, I tell them these are the two reasons why I'm seeing you today. Thanks.
There's another question from Ronald Go, and he asks if you know if regular xanthelasms have similar mutations as xanthelasms associated with histiocytosis.
It's a very good question, and the answer is no. It is not believed that they have similar genetic profiles. So it can, if a genetic alteration is found, it would be more clinching of the diagnosis of histiocytosis.
Then one last question, because it's already at least 6 o'clock where I live. can you comment on specific differences between various histiocytosis like LCH, Ertam-Chester, Rosa-Dorfman in terms of ocular manifestations?
Yes, so this is relatively preliminary data, but the thought is that LCH patients tend not to have as much involvement of their choroid and retina as non-LCH. So non-LCH patients statistically are more likely to have involvement of their choroid.
Yeah. Okay, thanks. Thanks a lot for your talk. I'm just ending this session with a slide that shows you ways to support us. The one is Amazon Smile, and the other one is, of course, to become a member. Any active involvement will help, of course. And the other thing is we have a survey of the session. Please complete this so that we can improve. Thanks a lot to all of you, and have a nice day or evening or morning.